Hello and welcome to Module 1. In this module, we will be discussing NAVA. One of the main questions I get whenever I am teaching somebody or a new therapist is just for the first time hearing of NAVA. It is, what is NAVA? And basically, the best way I describe NAVA is that it's a either an NG or an OG, however you decide to put it in. You can put it through the nasal or the oral um, cavity down the esophagus, and this gastric tube can still feed the patient or empty stomach contents, and it has a series of 5 electrodes in it that measure the activity of the diaphragm. And the activity, I mean the electrical activity. And this gives feedback to the ventilator so that it knows the exact activity of the diaphragm, and it can either synchronize with it or monitor it. And it's a very crucial tool that we are starting to see in the adult population. This in Europe has been mostly used on the adults. In the USA, it's mostly been used on pediatric or infant patients. And so we're starting to try to use these on all populations because we're learning that we get a lot of really good data from this. The next question I commonly get is, who needs NAVA? It's really not designed for anyone in particular. I think it's more of a trained eye and how we think of ventilation and anything like that. But basically, if I had to say there's a population for it, it is patients that have either a hard time triggering, so patients like emphysema or COPDers who have a lot of auto PEEP and they have to overcome triggering from the ventilator. The other thing is patients that are very weak or frail or malnourished. We know that the diaphragm is one of the largest muscle in the body, so it is important that if we are going to keep these patients ventilated for a period of time, then these muscles, they deteriorate, they have muscular atrophy, and it's important that we use this tool to start rehabbing these patients and making sure that their synchrony is good. When looking to place NAVA on a patient, there's a couple things you need to consider. The first thing that you do is you basically have to run down a module and a cable and place this in a ventilator, because not every hospital that buys Servo I's or Servo U ventilators have these modules. You typically have to buy them aftermarket from the company or package deal with them. Once you have this material, you also have to buy a special made NAVA catheter, the OGNG. From there, if you're going to place it on a patient, you have to make sure that there's no contraindication into dropping in a gastric tube in this patient. And then from there, you're going to measure a NEX measurement, which is nose to earlobe to xiphoid process. From there, you're going to place this into the ventilator. This ventilator calculation, or this measurement you give, will algorithmically come up with a number for placement, and from there you're going to run through a series of screens to make sure that you're basically refining out the cardiac, the nerve, and the electrical activity from the heart, and it's only picking up the activity from the diaphragm. So once you place a NAVA catheter in a patient, and you've ruled out that you have no activity from the cardiac system, and you are picking up the electrical activity from the diaphragm, this is kind of what the screen looks like. So in this patient, you can typically start by overlaying the electrical activity of the diaphragm over your pressure waveform. If you see that you're missing triggers or your end exhalations are off, then it would be probably beneficial to go to NAVA mode on a spontaneous breather. Here you can see that the top waveform has a pressure, which is in yellow still. The green's flow. It looks like it has the volume missing, but it would be there. and it looks like they're exaggerating the purple here, which is the NAVA activity. So when you place this, you're going to get two new readings. One of the main ones is your EDI peaks, and that's basically how you understand how hard the diaphragm's working and if you're going to make adjustments or not. So when you have a patient on NAVA, the first thing you look at here is the EDI peak. You would prefer, literature fluctuates a little bit, but I go off a range of 5 to 15. So below 5, you're placing the patient at risk of muscular atrophy, where you're not working the muscles hard enough and they're going to start to deteriorate. Above 15, you're working too hard, so the muscles will fail or strain too much and would create respiratory failure, which ironically they're probably already gone to vent for, so you would need to assist them more. In NAVA, basically, if you're 15 or above, then you need to increase your EDI level or your NAVA level, and that will assist the patient more. If you're below 5, then you need to decrease it and it'll assist them less and make them work harder. I kind of see this like if you're lifting weights and you have a spot partner and how much they're assisting you. So NAVA's capabilities are very strong. Whenever I first started using this, there were micro aspects in the waveforms that I couldn't tell what they were. Since I've started using NAVA on patients, I can say that I ignorantly maybe had things going on that I just didn't know were there. You can see here these red lines in this first pressure waveform. The diaphragm's breathing in and the vent's not giving a breath, and there's a pressure or a delayed trigger. And then once it finally does give the breath, the patient's actually starting to exhale, so it's holding and forcing pressure in while the patient's exhaling. You can imagine how uncomfortable this might make a patient, or how anxious or how out of sync. They're already on a breathing machine. They already have very uncomfortable things going on to them, not to mention this ventilator is not working with them. So synchrony is a very, very pivotal issue in reducing sedation and things like benzodiazepines like Ativan and things like that. And it's going to help your patients wean quicker, use their muscles better, and basically transition off these ventilators quicker. There's a lot of studies that prove that it does help with this. There's a few studies that have yet to be discovered and how it relates to P.1s and things like that. But this is the kind of gold standard of synchronizing your patient on a ventilator.